Hello everyone, this is Dr. Saroj Siddiqui from the platform of UKMLA with DSS, and let's just begin our ethical station. And the very first structure that we are going to do, and the very first topic that we are going to do in the ethical category, is going to be the breaking bad news, also known as the BBN sessions. Okay, and BBN sessions are like really common, and there wouldn't be any day. It's unlikely that the BBN doesn't get tested on a particular day. Okay, so like there are like 8 to 9 different topics of the breaking bad news station, and every day and every shift there would be one breaking bad news station, because this is a very strong skill set that a doctor working in the NHS should have, because very often you would have to break some kind of a bad news or the other. Number one, and number two, this is the kind of station that tests your highest level of your IPS skills. Okay, and the highest level of your ethical skills that you have, that how much you are able to focus on the ethics, how much you are good at communicating and talking about difficult conversation. And breaking a bad news to a patient is a difficult conversation, and you need to be on the top level of your communication skills when it comes to breaking a bad news. Okay, so yeah, it's very important, and it tests a lot of different parameters, and you need to make sure that you are doing it really well, you're doing it very naturally as well. Okay, so we'll go through the structure that we need to follow for the breaking bad news station. But before I begin the ethical category, I would like to tell you that we follow a layer system in the ethical categories. Okay, so they're going to be different layers of data gathering and management combined. Okay, that you need to follow in the ethical scenarios. Number one. Number two, there is no fixed structure for the management. Okay, the management would be incorporated in these layers only. Okay, so you need to make sure that you pay attention to the entire structure, to the all the layers that are being taught in the ethical scenario, in the ethical categories. Okay, so you need to keep that in mind. All right, so let's just begin with the breaking bad news station. Okay, there are 8 to 9 different BBN cases that you should be aware of. Okay, and there is no specific way to identify it from the case notes, but since there are 8 to 9 different cases, you should know that okay, this can be a BBN case. Okay, now you can see that this is Mr. Ali, 77-year-old man who collapsed at home, was brought to the hospital by an ambulance. The neurosurgeon assessed the patient and classified the condition as terminal. Okay, so that means that okay, the patient is not going to improve anytime soon, as they felt an operation wouldn't resolve the situation. The CT scan of the head was done, and it showed massive intracranial hemorrhage. The neurosurgeons believe that it's a berry aneurysm and have decided palliative care plan. Okay, so you know that this is a palliative care BBN. The other BBNs include palliative care because of bilateral stroke, because of a stroke, because of intracranial hemorrhage, like it is seen over here. Then there are a few BBN cases in which a patient of atrial bypass has had intraoperative bleeding. Then there's a case of pelvic fracture. Then there's a case of breast cancer, ectopic pregnancy, osteosarcoma. Okay, so there would be different situations in which you have to break the bad news, and like I mentioned, these are like 7 to 8 different cases. Okay, so after reading the task, you should get an idea that okay, this is a breaking bad news station. Okay, number one. Number two, before I start off with the BBN, okay, what I would like to tell you is that this is going to be a sad station. This is going to be a station in which you have to do a difficult conversation. Okay, so the basic ground rule for PLAB 2, that is you need to be very energetic, you need to be have a certain kind of a body language that shows that you are out there. Your physical presence and your body language should be very happy, jolly, but not always. Okay, specifically in a few ethical scenarios like the breaking bad news station or maybe the angry patient station. Okay, you cannot just start off the session that hello, I'm Dr. Saroj Siddiqui, one of the FI2s in this acute medical unit. Am I speaking to Mr. Adam Smith? Okay, you cannot do that. Why? Because just think about it. You are about to break a bad news. You are about to declare a patient as terminally ill, or you're about to declare somebody having cancer, and you're beginning your station with full energy and full zeal and full enthusiasm and excitement, and then the next minute you would be like that, okay, your father's terminally ill and there's nothing that can be done. Okay, so that wouldn't make sense. Okay, so always try to make sure that whenever you're beginning the station for the breaking bad news, okay, you have a lower tone, okay, as compared to the normal. Okay, do not be very energetic, do not be very excited that you are being very happy to break this bad news that the patient is terminally and then the patient is eventually going to die. Okay, you don't want to show that excitement. Yes, it works for other stations because you need to have that kind of a body language that you are welcoming, and you are confident and you want to communicate, and you know how to communicate. You want to give that impression in most of the cases of lab 2, but not for the breaking bad news session. So always keep a lower tone. Okay, then you're just going to introduce yourself in a very nice way that hello, Mr. Adam. I am Dr. Sarosh Siddiqui, one of the FI2s in this acute medical unit. I can see from my notes that you are related to Mr. Smith. Am I correct? Yes, doctor. Okay. Can you please tell me how you are related to him, and can you please just confirm his age for me? And then they'll answer you. Okay, and then you start off with the first layer. When you'll do an introduction like this, automatically the relative or this patient or the attendant, they would get an idea that doctor is having a low tone. Then his body language states that, okay, he's not very excited about the conversation that he's about to have. That means that there is something wrong. Okay, that means that there may be something wrong. Okay, so even before you've broken the bad news to them. Okay, your body language and your entire situation that you're trying to create gives an idea. Okay, and this is what would help the patient or the relative get mentally prepared. Okay, and in the initial layers, that is what you need to do. You just need to work on making sure that the patient gets mentally prepared, or the relative gets mentally prepared to receive that particular bad news. Okay, so yeah, that was one thing. Then you start off with the first layer that, okay, so I have some important updates regarding your father that I need to discuss. But before that, will it be okay if you can answer a few questions for me? Okay, and then they'll be like, yeah, doctor, but please tell me what is wrong with my father. Is my father okay? Okay, so they're going to ask that. But why? Because in the very first impression you have given is that something is wrong, something is like not all right. Okay, so they would show some concern, so you're just going to reassure them. Do not lie to them that yeah, their father is 100% fine and all, and everything is okay, he's walking, he's talking. Don't say that, but just try to give him that impression that he's in safe hands right now. So you can just say that yeah, your father is in the safe hands right now, the doctors are taking care of him, the nurses are there to take care of him, and that is what I want to update about your father's condition. So will it be okay if we can just have a small chat, and then I'll explain each and everything to you in a lot of detail, Mr. Adam? So you see my facial expression, my body language that I'm trying to portray in this particular scenario. Okay, and then you ask about that. Okay, how much idea do you have about your father's condition? What have what have been told to you so far about your father's prognosis? Why did you bring him here in the first place? Okay, do you have any idea what your father developed? Do you have any idea what the medical team and what investigations we did on, on your father? Do you have any idea what are the chances of your father recovering from this particular condition? Okay, so this is what the introduction and the repo building is. Okay, this is the introduction that I just talked about, and the repo building is the initial conversation that you have with the patient. Okay, so that is layer number one. Okay, more of the idea aspect of the ice that we were doing in the counseling session. That is what you know the first layer is all about. Check their knowledge. How much do they know about their relative's condition? How much they know about the prognosis? How much aware they are of the situation? Okay, because let's suppose if they are not actually aware about anything. Okay, maybe they do not have an idea that the patient has had an intracerebral hemorrhage. They may just think that, okay, the patient just fell down and they just brought him to the A&E, and they might be expecting, yeah, it's just a fall, the patient would be fine. Okay, so you need to understand their understanding. Okay, whether or not they understand the gravity of the situation, whether or not they have the idea that okay, it is a stroke. They have an idea that it can be something potentially fatal or it can be something dangerous, whether or not they have an idea about that or not. Okay, so that is why the very first layer is like really important. Okay, um, then you move on to the layer number two. Layer number two is basically assessing the risk factors and the psychosocial aspect. Okay, now the risk factor of the condition. Okay, like for example, if this patient has had uh, bilateral stroke or intracerebral hemorrhage, okay, you're going to ask about the possible risk factors like diabetes mellitus, hypertension, lipidemia, family history, smoking, alcohol. Okay, and if this patient, if this was the case of patient developing aortofemoral bypass and developing a bleed after the aortofemoral bypass, then the possible risk factors would have been use of blood thinner medications, okay, any bleeding disorders, smoking, family history of bleeding, okay, and even hypertension as well, okay. So that would be the possible risk factors. And if somebody comes to you with breast cancer and you have to break the news of breast cancer to them, then the risk factors would have been different, in which you would have asked about early menopause and late menarche, and then you would have asked about the use of OCPs, you would have asked about smoking, you would have asked about the family history. Okay, so it basically varies from cases to cases, the possible risk factors. Okay, so the risk factors is like really really important. Okay, before the risk factors, as you can see that I've mentioned the history of the disease. Okay, that is the incident. So you may just ask about it if they haven't told you in the layer number one that what happened, why did they bring him. So you may just ask about the incident, like for example, um, this patient he collapsed. Okay, so the history of the incident would be the BDA, that what happened before he collapsed, what happened during his collapse, what happened after he collapsed, was he conscious, did he lose any consciousness, did he slip, did he trip over something, did he have any numbness or weakness in any part of the body, did he have any jerking movements. Okay, so just ask about the incident, okay, if there is any, and if they haven't told to you about it in the first layer. Okay, then similarly for the breast cancer patient, you may just ask about the OD para of the lump, that okay, can you please tell me since how long you've been having lump, when was the first time you developed it, is it just on the one breast, is it there on both the breast, can you please just tell me the size of it, and don't go into a lot of detail of it. Okay, just the what, when, why and how. Okay, how did you note it, what is it, since when are you having this particular lump. Okay, so the history of the disease and the incident only if it's not covered in the layer number one. And then the possible risk factors we have already talked about, that what can be the possible risk factors of different conditions. Okay, then the psychosocial aspect is also really really important, and you need to do this in the data gathering. Okay, and this is the psychosocial aspect of the patient. Okay, because there is a very strong possibility that you may be talking to the relative. Okay, so in the layer number two, the psychosocial aspect is basically not the psychosocial aspect or the psychosocial parameters of the relative itself, but it's basically you're talking about the psychosocial aspect of the patient. Okay, who is at home, who does the patient live with, what did patient do for a living, what were the hobbies of the patient. Okay, just to make sure that you are covering the possible psychosocial parameters. Okay, why is this important, who does he live with and who is at home, and what did he do in his free time. All of this is important because there is a very strong possibility that after you break the bad news to the patient or to the relative, they may say that doctor, I want to take my father home. Okay, so you got to ask about it, that okay, who is at home, how are things at home, what do you do for a living, if you don't stay with your father, who is going to take care of your father. Okay, you would have to address all of those situations and all of those questions later on in the management part. Okay, so ask about it. Other than that, a really, really important question in the layer number two, when you are assessing the risk factors and the psychosocial aspect, is basically advanced care planning. And we have talked about it in one of the counseling sessions. that what are this advanced care planning, that did he have any advanced directive, okay, or do you have the lasting power of attorney, or are you the next of kin, okay. Why? Because think about it, you are, dealing with a patient who doesn't have mental capacity, okay. And if the patient doesn't have mental capacity, then I talked about it in the previous lecture as well, that there is a step ladder that you need to follow to take the clinical decision making, whether or not the patient has an advanced directive that stated that maybe the patient doesn't want palliative care and the patient always wants an aggressive treatment, okay. And if there is not an advanced directive, then the lasting power for any uh, the decision may be given to someone. Someone might have been appointed to take the medical and the clinical decision on their behalf, or if there is no one, then whether or not somebody is the next of kin, okay. So all of these things need to be considered. So just ask about the question of the advanced care planning, that did he have any advanced directive made, and are you the lasting power of attorney, okay. So yeah, layer 2 is it's a bit detailed, okay, and that is what is going to make most of your data gathering, okay. And the marks that you're going to receive in your data gathering would be on the basis of these layers, okay. So 1 mark would be for layer 1, and the 3 marks would be for layer number 2, okay. And I've talked about all the 4 parameters. One is the idea, number 2 is the history of the disease and the incident, third are the possible risk factors, and number 4 is the psychosocial aspect. Cover these 4 things in BBN, you're gonna get 4 on 4 in data gathering. But make sure that you do it the right way, and get your sentence structures right in this case, okay. Now, now, since you've done the data gathering, okay, now comes the layer number 3, okay. And once you move on to the layer number 3 from layer number 2, okay, your tone should go further down, okay. So we are already dealing on a lower tone, now it should go a bit more low, okay. Like for example, you need to assess the support system of whom, of the person to whom you are breaking the bad news, okay. And how are you going to do that? Okay, thank you so much for answering all my questions, Mr. Adam. I would like to ask you, are you on your own right now? Why, doctor? Because I have some important updates to share with you. So, would you want to call someone before we discuss those important updates? And then, they would automatically be like, okay, like they want to address some issues, they want to, me some update, and they want someone to be there with me right now, okay. That means that it can be a bad news, okay. So the patient is, or the relative is, automatically getting mentally prepared, that okay, something, that I'm not expecting may be coming, okay. Or you can ask them that would it be the right time to discuss a few important things with you, or would you want to call someone and schedule it for some later, when you feel that you are mentally ready to take some important updates, okay, with a lower tone, okay. Very important. A lot of people, they don't do this, and they just completely miss out on this layer, and then they move forward because there's so much, it's so much in their head that we want to complete the station, we want to just break the bad news as soon as possible, and then they miss out on this, and this is what have a very very negative impact on your IPS. That even if you just say out the bad news, if you're not doing it properly, if you're not doing it the right way, then you would not be getting marks for your IPS and for your management as well. Because just think about it, like there is no medical knowledge involved in this. There is no clinical thing that is expecting that they are expecting from you. Okay, they have mentioned everything, that the patient is terminally ill, palliative care have been decided. Okay, the patient is unconscious and breathing independently. Okay, so they're not trying to assess your knowledge that whether or not in this case a palliative care would be there in the plans or not. Okay, if they would have expected that, then yes, they would have given you the marks for just saying palliative care or just verbalizing palliative care. But all of it is already written there. Okay, they have written down the entire story for you. So what they are testing you on in the management part as well is how you are breaking the bad news. Are you able to create that scenario? Are you able to create that situation? Are you able to create that environment of the breaking bad news? Okay, so make sure that you are using the right tone in the beginning, and then you are assessing the support system in the correct way, okay. And then after you are done with that, The next layer is paraphrasing, okay, in which you are just going to say that, okay, so your father presented to us with a fall and was unconscious, and in order to find out the cause, we did a CT scan of the brain, okay, and it's also mentioned in the task, okay. So nothing new, okay, it's just the way that you say it, okay. We did the CT scan of your brain, of your father's brain, okay. That is layer number 4. You just paraphrase the entire situation, okay, because now you are coming to a point, and now you are walking the patient through the incidents that happened, okay. Your father collapsed, he was brought to the A&E, we did some CT scan, and now what will happen, okay. So you need to build up that particular, situation, and build that scenario, so that you are ready to break the bad news. And then after you are done paraphrasing, okay, still you are not ready, still you are do not break the bad news, okay, then you give something called the warning shot, okay. Instead of directly giving the bad news that, yeah, this is what has happened to your father, say that, we did a CT scan, and we did some scans, and unfortunately, Mr. Adam, or unfortunately, Mr. Anwar, whatever the name of the patient is, I do not have a very good news for you. So you see, my tone went further down. I do not have a very good update for you, Mr. Adam. Unfortunately, the news that I have is not something that you would be expecting. Still, I haven't shared with the patient that, okay, there is a massive bleed in the brain. I'm just trying to, make the patient ready to, digest this news. Okay, I'm working on his adaptability to this news. Okay, this is what I've been doing in the initial 5 layers. Okay, out of the 8 layers that are there. Okay, and then the patient would say, "Doctor, just tell me what is wrong with my father. I want to know." Okay, and then you would go to the layer number 6, which is the main layer. Okay, that is being tested in the exam. That is breaking the bad news. Okay, and how are you going to do that? Well, Mr. Adam, the CT scan showed that there is a massive bleed in the brain that has led to irreversible changes. That means that it has caused a damage to your father and put him to a point of no return, and doing anything aggressive on him would not help us reverse the condition. And I'm really sorry to tell you that it would be very, very difficult to bring your father back to the normal condition that he was in. And then you do the silent pause. So you see, I explained it to him. I explained the gravity of the situation to him. That, okay, there is a massive bleed in the brain. Fine. So what? Like, the brain, a bleed in the brain. Many people have strokes. Okay, they recover from the stroke. They go into aggressive physiotherapy, and they eventually come out of it, and they eventually live the normal life. But you need to explain the gravity of the situation, that it has led to irreversible changes, and it has put your father to a point of no return, that doing any medical intervention would not be able to bring him back to the normal life that he was living. That is what the meaning of terminally ill is. Okay, you can see that this condition is terminal, so you need to explain the situation, that, okay, this is a terminal condition, it has led to irreversible changes, your father is at the point of no return, the things have gone way out of our hands, we will not be able to bring back your father. It would be very difficult for us and your father to recover from this, to fight from this situation. Okay, explain the entire thing. And if it's a cancer case, then you're going to say that, okay, we did a biopsy, and we run some tests in the histopathology lab, And unfortunately, Miss Anna, I would like to tell you that the biopsy results shows that you have a stage 2 breast cancer. Okay, be very vocal about it. Stage 2 breast cancer. Don't say that lump may be something sinister. It can be, it most likely it is a carcinoma. Don't just play around. Just be very direct. Okay. And what a lot of people do is, because they don't keep a track of their time, uh, what they do is that they just run to the layer number 7, and they forget about this silent pause. It is a very essential thing. Do not speak anything. Okay, after you've broken the bad news, just think about it. You've shared a very difficult conversation, you've shared a very difficult news with the patient, and you haven't let them absorb that particular news, and you're just going, yeah, yeah, I'm going to put in palliative care, I'm going to do this, I'm going to do that, I'm going to do blah 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 blah. That would really affect your management as well, because that means that you're not breaking the bad news, okay, in the right way. Number one. Number two, that would have an effect on your IPS skills as well. That means that you're not human enough to understand emotions. Okay, you have broken a bad news to someone. You've told them that they have cancer, and all you're concerned about is what you're going to do next. At least let them you know absorb. At least let them digest what you've just told them. Okay. And when are you supposed to speak? Okay, when the simulator says that, okay doctor, what's next, what is going to happen with my father, or what is going to happen with me. Or if somebody if they just make the eye contact and they are waiting for you to speak, okay, then only you are supposed to speak. Other than that, make sure that the silent pause is there. Okay, make sure that you don't just rush to the management part. Okay, because you think that, okay, if I just do the management, I may score more. But the kind of negative marking that you'll get into just because you haven't given the silent pause would have a much more negative effect. Okay. Other than that, a lot of people they just follow the scripts, and it's because it's written in the script that you need to offer tissue paper to the patient who is crying after hearing the bad news. You need to offer a glass of water to someone who is who has just heard a bad news. Okay, so a lot of people they just break the bad news, and do you want some tissue paper, do you want a glass of water? Don't do that, because everyone is doing that, and it just makes you look stupid. That, okay, the patient haven't asked for a tissue paper, the patient is not actually crying to a point that they need some tissue to wipe their tears off. The patient has not asked for a glass of water, and just because it is there in the script, just because it has been taught by many tutors, just because it is written in XYZ notes, okay, you are just offering tissue paper and water. Okay, the examiner laughs at you because they know it's written in the scripts, they know that it's written in the notes, and you're doing that, so they would just laugh at you, and then don't expect to then clear that particular station. If you end up doing silly habits like this and follow silly scripts like this, that do you want a tissue paper? I don't want a tissue paper. I just want to like at least absorb the news that you just shared with me. Okay, do you want a glass of water? No, I don't want a glass of water. I just want to know what's going to happen with my father next. Even if you give me a glass of water, I would not be able to swallow it. That is the kind of news that I have received. So do not just end up offering things just because it is written in the notes. Okay, it makes you sound really stupid. Okay, do not follow those steps, because think about it, 200 people, all of them are following on the same day or on the same week, and the examiner is just sick and tired of listening to this dialogue. Do you want some water? Would you want me to get some tissue papers for you? Okay, so don't do that. Okay. So yeah, after the patient has made some eye contact, or the relative have made some eye contact, then you move on to the next layer. Okay, that is what's next. Okay, and then you have to explain. Okay, if it's palliative care that you need to explain. Okay, like for example in this case, then explain palliative care. In some cases you would have to explain what a DNA CPR is. Okay, or what BNI means. Okay, and then in the cases of cancers, you may have to explain about chemotherapy, radiotherapy, and surgical options. Okay, and in the case of aortofemoral bypass patients having an on table bleed, okay, you would have to talk about the blood transfusions. Okay, So these are the different management pointers for the different type of station, and it varies from case to case. Okay, so make sure that you have gone through all the cases, you have read the management, and you have read the explanation part. So just read, use those notes to get the content and try to apply all of those content to these particular structures that I've been teaching. Okay, number one. Number two, palliative care is one of the most common explanation that you may have to give in a BBN station. Okay, even in the patient of dementia who have been diagnosed with terminal dementia, even then you would have to explain palliative care to them. So what a lot of people make a mistake is that after the patient has made eye contact, or after the relative have made the eye contact, they say that okay, so that we had a multidisciplinary team meeting, and the consultants reviewed your case, and the consultants decided that doing any aggressive medical treatment or any form of medical intervention would do more harm to her as compared to benefit. As a result of which, we have decided to put your father on something called the palliative care. Do you have an idea what the palliative care is? And the relative is going to say, no, doctor, I do not have an idea what the palliative care is. And then you're going to say, no problem, I'm going to teach you what the palliative care is. Why do you want to do that? Of course, they wouldn't know what a palliative care is. Okay, so just save your time and just explain it to them in one go. Na? That palliative care is a form of supportive treatment that is given to the patients towards the end of their life to keep them pain and distress free. Okay, in just one line, just explain that what palliative care is, and then ask them, okay, doctor, do you okay, Mr. Adam, do you have any concerns regarding it so far? Am I making sense? Do you have any queries that you want to discuss with me? Okay, and then ask a question. Okay, don't do this, that do you have any idea what palliative care is? Of course they're not going to have any idea what palliative care is. Okay, so you got to explain palliative care. Okay, then you may have to explain DNA CPR, that, and how you're going to explain that. Okay, Mr. Adam, the multidisciplinary team have decided to put your father on something called DNI and DNA CPR, which means do not intubate and do not attempt cardiopulmonary resuscitation. So I'll explain it to you what it means. Patients who are terminally ill and the patients who are on palliative care, there is a very strong possibility, Mr. Adam, that their heart may stop beating, or their lungs may stop their function and provide oxygen to different part of the body. In situation like this, when it occurs to someone who has good chances of recovery, and someone who is not terminally ill, unlike your father, what we do is that in case in which the heart stops, we do some manual compressions or manual chest compressions to make sure that we restart the heart. And we also put these patients on artificial mechanical ventilation, that is called the ventilator, in an ICU. For your father, we are not going to do anything aggressive or anything as intensive as this, because we believe that putting your father through the distress of cardiopulmonary resuscitation or chest compression and inserting a tube in his airways to put him on artificial ventilation is not going to yield any benefits for us. It is only going to make more harm as compared to the benefit. And you wouldn't want your father to be in such a distress and in such unnecessary pain towards the end of his life. Okay, so that is how you're going to explain it. First of all, explain what CPR and intubation is, and then explain that why we are not doing it in your father's case. Okay, and in the cancer's case, you're going to talk about chemotherapy, radiotherapy, and surgical options and blood transfusions. Okay, that is like simple. You can just verbalize it. Okay, but the DNA CPR and palliative care was too difficult things, so that's why I went to into the details of it. Okay, then you're going to ask about them, that okay, do you have any concerns after you're done with the what's next, or the basically the medical management where needed. Okay, so once you're done with that, you're going to say that okay, do you have any concerns? Okay, so they are going to drop a lot of concerns. Okay, like for example, the first concern that they may just have is that, doctor, are they going to die? Okay, and this is a very common question that you may get in the cases where you're deciding palliative care for the patient. Okay, are they going to die and how you're going to answer that? Unfortunately, they are not going to make it. Okay, if it's a palliative care station or it's a DNA CPR or kind of a station, you got to say that unfortunately they may not be able to make it. Okay, be honest. Do not say that yeah they're going to survive. We're going to try our best, because you know that this patient is terminally ill, and terminally ill patients eventually they don't you know make it very far. Okay, so just say they're not going to make it. Be very honest. There is no need to be very diplomatic about it. Okay, you need to be transparent and you need to be honest in your conversation. Just because it's a difficult conversation, that doesn't mean that you are allowed to hide stuff from the patients. Okay, and if it's a manageable condition, like for example, the aortofemoral bypass bleed, that can be managed. Breast cancer second stage can be very well managed. So you can just say that it is a pretty manageable condition, and many people go through it. The doctors are looking into the case, or you'll be seen by the specialist, and hopefully you will also get through it. Okay, so you need to see what are the cases in which you have to have the reassuring kind of approach, and what are the cases in which you have to be honest about the patient's condition. Okay, then when you talk about palliative care and when you talk about no CPR, okay, they may just have some concern that are you giving up on my father, because you said that you're not doing any aggressive medical intervention that is done on all the patients there in the ward. Then what does that mean? Are you trying to give up on his condition? Okay, so you gotta reassure that I'm really sorry that I gave you that impression. But we do not give up on our patients. As I told you that we are just doing what is best for him at this moment. Okay. Then, on the patients who are about to die, who are terminally ill, they may just drop a concern to you that, doctor, can you just delay that death, because my younger sister or my elder brother is in Germany or is in Australia. They would, want to be there. They would want to be here. They would want to come and meet my mother, meet my father for the very last time. Okay, so do not say yes or no. Okay, just be very nice in answering this question. That unfortunately that is something that is completely out of our control. We will just wait for the nature to follow its course, and we'll just see what the nature does, and we'll just leave this situation in the hands of the nature. Okay, so delaying the death concern can come up to you, and you should know how you to answer this. Then you can see that there might be a concern that can you take him to the ICU, or why don't you take him to the ICU, or why don't you put him on a ventilator or something. Okay, and see this task. The patient is lying unconscious, but he is breathing independently. Okay, so you gotta use this piece of information in addressing this concern. That well, currently he is breathing on his own, so the ICU will not be beneficial for him. We take those patients to the ICU who need any artificial ventilation and who are not breathing on their own. And secondly, putting him on ventilator or putting him on mechanical and artificial ventilation would do more harm to him as compared to the benefits. Okay. Then the patient may have some concerns that, doctor, is the palliative care euthanasia? Like, are you trying to deliberately kill someone? Are you trying to deliberately, kill my father? Okay, then you're going to say that no, that is something that is not legal in the UK, and palliative care is not at all euthanasia. It's basically a form of a supportive treatment. Okay, and it's not basically withdrawing any treatment. And then they may ask you that, doctor, can I take him home? Okay, so you got to ask what were his last wishes, and that's why you ask about the advanced care planning. Okay, so if his last wishes was to stay at home during his end times, then yes, let them go home. Okay, then you got to ask about who is else at home. What do you do for a living? Okay, and you have already asked this question over here as well. Okay, who is at home and like how are the things at home? Who works at home? Okay, so if these conditions allow, then you can allow the attendant or the relative to take their father or to take their relative home. But if these conditions are not favorable, then you need to give the patient the advice of staying in the hospital, or give the advice to the relative of keeping their relative in the hospital to make sure that the palliative team can provide effective care that may not be provided at home. Okay, but if it's the last wishes of the patient to stay at home, or if the next of kin and the lasting power of attorney have that wish, and if you feel that the living condition is appropriate and there would be someone to take care of the patient, then you can definitely send them home. Okay. uh, then they may say that, do I need to call other relatives? So you can say yes, that definitely you can call other relative, because in situation like this it's always better to you know have a good support system available. Okay. Then in the breast surgery cases or in the breast cancer cases, okay, they may just drop a consent that, doctor, I don't want my breast removed, and it's something quite embarrassing, and I don't want to lose my breast. Okay, so you would have to counsel the patient on this regard, that we would have to remove your breast, or we may have to remove your breast, because breast cancer is something which spreads like wildfire, and it can spread to your entire breast as well, and it can spread to the muscles and to the lymph nodes that you have, and then eventually it can spread to your entire body and can become fatal as well. So it's always safe to get the breast removed wherever it is needed. Okay. But then the patient is again going to say that, no doctor, it's kind of embarrassing, I don't want to be moving with just one single breast, and people will laugh at me, people will not find me beautiful anymore. So you're going to suggest the alternative, that there are plastic surgeries available and there are breast implants that can be suggested to you. So there are multiple options available that will help you get through this concern. Okay, so try to solve the situation, try to address this situation, and try to suggest different solutions. Okay. Then the patient of osteosarcoma may say that, doctor, will I be able to play football again? Talk about physiotherapist, that okay, after you're done with your surgery and chemo and radio, the physiotherapist is going to work on you, make sure that you get your bone and muscle strength back. The patient of atrial bypass, the woman who would have had a bleeding intraoperatively, okay, they may say that, doctor, was there a mistake in the surgery that led to the bleeding while you were doing an atrial bypass? Okay. And you're not going to be defensive. Okay, you're not going to say that, yeah, there is a probably there is a mistake in the surgery, because you are not aware. Okay, you don't know whether or not there was a mistake in the surgery or not. Okay. So make sure that you answer it very very diplomatically, and be honest about it, that I'm not actually aware if there was some error or not. However, what I'm going to do is that, number one, I'm going to check the case notes or the intraoperative notes to see if there was any medical error that happened. Number one. And number two, after the surgeons are done with the surgery, I'm also going to have a talk with the surgeons, and I'm also going to request them to come and have a talk to you as well. Okay. So be honest. Okay. And then tell the course of action that you're going to take. The honesty is that you're not aware whether or not there was a mistake in the surgery. Okay. And what you're going to do is that you're going to check the case notes to find out whether or not there is something wrong that happened in the surgery, or you're going to go and talk to the surgeons who did the surgery to make sure that everything was all right during the surgery. Okay. So a lot of concerns may be just thrown to you. Okay. And out of the 4 marks of the management, 2 marks would be on how you break the bad news. Okay. And how you address and how you talk about the next steps. And there is a possibility that you may be given 2 marks just to address the concerns, because there would be a lot of concerns that would be coming to you. In the other stations, what I tell my students and what I tell the candidates is to make sure that you are addressing at least like two concerns. But in this particular station, in the BVN station, I would like to recommend you that at least make sure that you are addressing at least three concerns of the patient. Okay. Make sure that you leave enough time after you're done with breaking the news and all, so that you are able to make sure that you're able to cater to at least three different concerns of the patient. Okay. So this is how you need to do the BBN. This is what the breaking bad news station is, and you need to master it, because most likely you're going to see it in the exam. Okay. Just one more thing before I end this lecture is the funeral services. Okay, many people, who are during dealing with their end of life stages, okay, they may need some assistance with the funeral. Okay, so the NHS doesn't offer funeral services. Okay, but there are some funeral services available in the UK, who can help in the post death proceedings, which includes the bereavement support, which is basically uh, talking to the relative, doing psychosocial therapy, let them get their sadness out and let them get their emotions out. Then providing that certification. Okay, then uh, planning the burial and planning the death ceremonies, and if there is any need for organ donation, if there is a possibility for organ donation, they also look into those regards. So for the patients who have died or they are about to die, you can offer funeral services, but do not offer it in the BBN stations. Okay, this is not for the Breaking Bad News stations. This is for the station in which the you're talking to a relative of a patient who has just expired or who has just died. Okay, in the BBN station, the patient has still not died. Okay, they are terminally and they may die. So do not just offer funeral services in this case. But since we were talking about death, we were talking about end of life care. So I just added this funeral services part in this particular lecture. Okay. So yeah, I've talked about the BBN in a lot of detail, okay, and I've covered different aspects, not just the data gathering, the IPS and the management, and how different cases were present and what you need to do in different cases. But make sure that you do justice to this lecture, and you apply these structures and you apply these layers in your practice. And there are 8 to 9 BBN cases. Make sure that you have done them all, okay, because it's a very high yield topic, okay. And if you have got any queries and any confusions regarding the BBN, then please drop them down in the comment box below or drop them down in my DMs on my social media. I would love to address your concerns. And if you've got any queries and any confusions, please ask them. And if you want to have a personalized walk with me, then scan the QR code for more details. That's pretty much it from my side. See you in the next lecture.